patent fallopian tubes, and mild male factor infertility. Here you can expect 20 to 25% success rate. But hardly we get this couple profile when they come to us for IUI. Now you have done everything. Now it's turn for stimulation protocol. So what stimulation, what to give, when to give, and how to go about it. So what your approach should be towards ovulation induction. The clinical approach to ovulation induction requires an understanding of the causes of anovulation, and the 4 most common ovulatory disorders include the polycystic ovarian syndrome, hypogonadotropic hypogonadism, primary ovarian insufficiency, and hyperprolactinemia. Can you do natural cycles when you are doing IUI? Yes. Without stimulation, you can do natural cycle IUI, and it is appropriate in those patients who have come to you only for ejaculatory dysfunction or vaginismus or cervical factor infertility. In these cases, you need not stimulate the ovaries. Just do the follicular tracking and at appropriate time place the washed sperms in the uterine cavity. Ovulation should be documented prior to proceeding with the unstimulated, that is your natural cycle IUI. How to monitor these natural cycle IUI? The most cost effective method is monitoring it by urinary LH kit. Once the LH surge is documented in first morning urine, you can perform IUI the next day. A large randomized trial showed that ovulation monitoring resulted in higher pregnancy rate. So at least do monitoring by the LH urinary kit. Now when you should go ahead with ovulation induction? Of course, when there is anovulatory infertility. The WHO has classified these ovulatory disorders into 3 groups. The group 1, where gonadotropin levels are low, estrogen secretion is low, and the cause is hypothalamic pituitary failure. Group 2, the gonadotropin levels are normal, estrogen secretion is normal, and here the HPA axis failure is the cause. And group 3, where gonadotropin levels are high, estrogen secretion is low, and the cause is ovarian failure. In our practice, we are doing mostly the COH when it comes to IUI for PCOS patient. So this is the guide that PCO cases, your first line, all the guidelines are emphasizing that before you proceed with the ovulation induction, the first line management is the lifestyle modification. I know it is very easy to say that come with weight loss, but we don't defer IUI. But you have to counsel them, and BMI, as I already said, it does not impact our IUI success rate. Counsel them for first line management, then start with your oral ovulogins, second line is gonadotrophins, and third line is IVF. What to do if they are having this POI? Because it occurs in 5 to 10% cases of anovulation. And don't forget, I know you cannot take them for IUI, but do counsel them for the higher risk of osteoporosis and cardiovascular disease so that she can monitor these things in her life. Hyperprolactinemia accounts for 5 to 10% of anovulation. These women are anovulatory because hyperprolactinemia inhibits gonadotropin secretion, presumably by inhibiting GnRH, and these women will come to you with amenorrhea or oligomenorrhea. That is why in our mandatory hormonal profile, prolactin is included, because it is responsible for 10% of anovulation, and if you correct this hyperprolactinemia, she starts ovulating, and without your IUI, she can become pregnant. Now, what should be the goal for your ovulation induction? Our goal is monofollicular development. Subsequent, we want monoovulation, single pregnancy, and birth of a healthy newborn. So this is all a very, very, what should I say, a dream come true goal, which rarely we can but in IUI we do want 3 to 4 follicles. The method of ovulation induction selected by the clinician should be based upon the underlying cause of anovulation, the efficacy and cost of the drug, and the potential complications associated with the method you have selected for ovulation induction. This is my favorite slide because only we fertility specialists get a chance to do the preconception counseling. Those who are doing only obstetric practice, patients come to you when they are already pregnant. So you have missed this window totally. So grab this opportunity, do counsel them, and what you should be counseling? Preconception, BMI, lifestyle counseling, folic acid supplementation. You have to correct her anemia, diabetes, thyroid, any other endocrine disorder, thalassemia screen like we are in Vidarbha area, and vaccination. Vaccination, now FOXY has come out with the guidelines about the preconception vaccination. It is there on the FOXY website, and FOXY recommends vaccination counseling mandatorily as a part of your preconception counseling. Now, which ovulation drug to choose? We all want a drug which has oral route, which requires minimal monitoring, which does not have hostile effect on the endometrium and cervical mucus, which gives us better ovulation rate and pregnancy rate, and the drug should have less chances of OHSS and multiple pregnancies. These are the stimulation protocols in our armamentarium: clomiphene, letrozole, CC plus gonadotrophins, letrozole plus gonadotrophins, and gonadotrophins alone. Whatever stimulation protocols you are choosing, you should start your stimulation on day 2 or day 3. Why? I have made it very, very simple for you all, that the recruitment of the follicle takes place only in the early follicular phase. If you are starting on day 6, day 7, you won't get the new follicles which you can recruit. There will be only the growth of already recruited follicles. So, you have to, whatever the guidelines are saying or whatever you are reading, start your stimulation protocols on day 2 or day 3. Now let us look at one by one all the stimulation protocols. Clomiphene citrate, at least our generation, we have grown up on clomiphene citrate, as this is the drug of choice for more than 55 years. It is simple to use, cost effective, fewer complications. But nowadays we don't use clomiphene, we all have shifted to letrozole. But you all should know, because clomiphene is there, it has its place. So it has two isomers, zooclomiphene 38% and N-clomiphene 62%. N-clomiphene is cleared rapidly, while zooclomiphene has a long half-life, and N-clomiphene is the more potent isomer with greater anti-estrogenic activity, and it is the one primarily responsible for inducing follicular development. This is the mechanism of action. You all can see that the CC binds to estrogen receptor and it depletes the receptor concentrations. The estrogen feedback loop gets interrupted and the FSH secretion is increased, leading to multiple follicle growth. You have to confirm the ovulation. So how you can confirm? We don't do the BBT technique also. We don't do the mid-luteal phase serum progesterone, but the theoretical part you all should know when you can say that this woman has ovulated. We all are doing ultrasound tracking, and on that we see whether she has ovulated or not. Before you go ahead, again I would like to emphasize that you have to rule out the disorders of pituitary, adrenal, thyroid origin, and as I said, hyperprolactinemia, because once you correct these endocrine disorders, the anovulation is sorted out and this lady does not require IUI. CC is started on day 2 or day 3, but you can start as late as day 5, never beyond day 5. which dose to start. I know theoretically we always tell that you should start with the 50 milligram dose and then you should gradually increase it in an increment of 50 milligram. But to be practical, we always start with the 100. In our first cycle, we don't start with the 50, start with the 100, monitor and see what is the response for this 100 dose. If there is failure of ovulation, it is called as clomiphene resistant, and about 20 to 25% of anovulatory women are clomiphene resistant. Whereas failure of pregnancy despite ovulation is clomiphene failure. When you should stop CC? This generation might not have seen, but I have seen when patient used to come and they used to take clomiphene from 2 years, 3 years because nobody bothered to check her previous treatment history, and she used to take clomiphene. मेरे पास भी 4 साइकिल कर ले, देक्स के पास गई, मेरे पास भी 6 साइकिल कर ले, मेरे पास भी 6 साइकिल कर ले, because many gynecologists are hesitant to use gonadotropin cycles when it comes to IUI, and many of the gynecologists, they don't have IVF facilities. So patient used to linger with that clomiphene stimulation for years together. What is the guidelines? The American College is saying you should not give more than 12 cycles of CC. How to monitor? This applies to both CC and letrozole, that if you are not using gonadotropins, simple LH urinary kit monitoring is more than enough. CC does give you a ovulatory rate of 80%, but the pregnancy rate is 30 to 40%. And of those who ovulate on clomiphene citrate, approximately 50% they do so at a dose of 50. Now you can read it a dose of 100. Another 20 to 25% 100 and 10% at 150. There is no benefit to increase your clomiphene dose in subsequent cycle once ovulation has occurred. So if your patient has ovulated in this cycle, say for example 50 or 100, but she has not become pregnant, don't increase the dose in the next cycle by 50. Stick to that dose on which dose your patient has ovulated. And why pregnancy rate is low as compared to the ovulation rate? You all know it is because of the anti-estrogenic effect on the uterus, cervix and vagina. This is the pathway how clomiphene affects cervix, endometrium and vagina for having anti-estrogenic effect. So do you have any strategy to prevent or rectify this anti-estrogenic effect? As of now, no, but you can try. You can start clomiphene stimulation in the dose of 25. You can start your stimulation on day 1, or you can add exogenous estrogen to minimize the anti-estrogenic effect of clomiphene. This is again to make my presentation complete. In our practice, we never give such high doses of clomiphene. There are studies where they have given clomiphene in the dose of 200 to 250. They have given for 8 to 10 days in those women who are refractory to standard doses. But logic is telling you once you increase the dose, there will be more of anti-estrogenic effect. Side effects, you should always remember. Clomiphene has its own share of side effects. Hot flashes are common in 10 to 20% of women, and additional minor problems you should be able to figure it out when she comes to you with pain, distension, nausea, vomiting or breast discomfort. Some women might have mood swings, depression and headaches. And side effects of clomiphene are not dose related because they can occur even in your minimal dose of clomiphene as well. Don't forget, in severe cases, clomiphene can have visual disturbances as well. Now coming to the letrozole, which is the 3rd generation aromatase inhibitor. This is the mechanism of action, that it inhibits aromatase in ovaries and peripheral tissues, thereby reducing estrogen levels. The negative feedback loop being not active stimulates the hypothalamus pituitary axis. GnRH release produces FSH, which leads to stimulation of follicles, and rising estrogen level from follicle suppresses FSH, leaving a single dominant follicle. That is why we say letrozole gives you monofollicular development over clomiphene citrate. So what is the standard dose regime? It is typically administered in the dose of 2.5 to 7.5 milligram daily, and here the dose can be adjusted in 2.5 milligram increments. It is administered the same way as clomiphene, that is day 2 or day 3. Latest you can start by day 5. There are studies where they are given letrozole for 10 days. However, most trials have focused on 2.5 and 5 milligram doses of letrozole. Sequential dose escalation of 2.5, 5 and 7.5 if ovulation does not occur on lower doses is widely used. Even that I am using in my practice as well. Higher doses, that is if you go beyond 7.5 milligram, it is associated with thinning of the endometrium similar to that seen with clomiphene citrate. And there are studies which has documented that if you go beyond 7.5, you will encounter the anti-estrogenic effects of letrozole. There is extended letrozole therapy that is administered in the step-up doses consisting of 1, 2, 3 and 4 tablets of letrozole. One tablet is of 2.5 milligram on day 2, 3, 4 and 5 respectively. However, this is associated with multiple follicular development, but it also gives you a higher clinical pregnancy rate. In nutshell, these are the advantages of letrozole over clomiphene citrate, that letrozole has a short half-life. If you stick to less than 7.5 milligram dose, there is no anti-estrogenic effect. It increases the uterine blood flow and there is less risk of OHSS and multiple pregnancy. If you encounter a patient with higher BMI, all the guidelines are recommending letrozole as the first line treatment for going ahead with ovulation induction. Again, this is my favorite slide because nowadays we have really become callous. When it comes to giving CC or letrozole, we assume that there won't be any multiple pregnancy. So this case is there on the internet where letrozole stimulation has given to sextuplets. This was a 32-year-old woman. Of course, she was having PCOS. She was started on letrozole and gradually her dose was increased. At 7.5 milligram, she developed many follicles. Of course, the gynecologist told her to refrain from intercourse, but typical patients, they don't listen to you. She went ahead and at 7 weeks, she was noted to have a sextuplet pregnancy. So remember, even if you are doing your stimulation with clomiphene or letrozole, you should know when to cancel the cycle. So when you will be cancelling the cycle? When you are seeing 3 or more lead follicles. Lead follicle means they are more than 16 to 18 millimeter. For gonadotrophin standalone cycle, lead follicle we consider as 16 millimeter and beyond. For oral ovulations, the lead follicle is 18 to 20 millimeter and beyond. So if you are having 3 and more than 3, you should document on your case paper. Tell them to refrain from intercourse, don't give trigger, don't do IUI. Rest, let patient do whatever she wants to do. Letrozole also has side effects in terms of hot flushes, fatigue and dizziness. Now this was all about oral ovulations. Now let us come to know the gonadotrophin stimulation. Market is flooded. Rather, it is really confusing. Day by day, we are having newer and newer gonadotrophins and companies are coming and they are briefing you. Basically, they fall into these categories: HMG, that is urinary HMG, then highly purified urinary HMG, urinary FSH, highly purified urinary FSH, and recombinant FSH. These are the 5 categories of gonadotrophins which are available. When you decide to go ahead and do the gonadotrophin stimulation, you have to consider these factors, that whether your patient will be able to bear the cost, the expertise required for this monitoring of this cycle, the implications of potential multiple pregnancy and OHSS. But if you know when to cancel the cycle, believe me, I am doing gonadotrophin stimulation since last 35 years and I have not encountered any OHSS or multiple pregnancy when it comes to my non-IVF cycle. IVF, so now we all have OHSS free clinic because we all use antagonist protocol, we give agonist trigger, and we do freeze all embryos. We don't transfer in that cycle. So IVF nowadays we just don't talk of OHSS. In IUI we have to talk of OHSS because many people, they don't realize that they have to stop or cancel the cycle. So you should be very strict when to cancel the cycle. And you have to use the most cost-effective gonadotrophins. Don't force your patient to use recombinant FSH. If you go on internet, if you read various papers, each and every paper is very, very clear that urinary HMG is equally effective as compared to the recombinant FSH when it comes to clinical pregnancy rate. I am talking of IUI cycles. So safely go ahead and use the urinary HMG because that is pocket friendly to your patient. If you go for recombinant, it will increase the cost, but it will not increase the clinical pregnancy rate. Problems with gonadotrophin, I have already said, multifollicle development in terms which will lead to multiple pregnancies and OHSS. Now what should be the starting dose of gonadotrophins? You have to consider the age of the woman, her antral follicle count and her AMH, if this is the first cycle, because that will tell you what will be your starting dose. And if she has come to you for a second cycle, then you have to see the response to the first cycle. What was the gonadotrophin which was started, what dose, how many follicles she produced. That will also help you in deciding the gonadotrophin dose in this cycle. There are various protocols, conventional, step up, step down, and very, very simplified protocol which I will be telling you. So first let us go through the theoretical part, then I will be telling you the practical part which you all can very easily follow in your day-to-day practice. The first is the conventional protocol where these are slides are from the studies. So they have used FSH. You go ahead and use urinary HMG. You have to start with 150 urinary HMG and you have to monitor the cycle. This is the conventional protocol. Now there is a low dose step up protocol. Remember, every stimulation you are starting on day 2 or day 3. So that is why I am not repeating when you should start. In step up protocol, you are starting with 37.5. After 6 days, you are increasing to 75. And based on the response, you are increasing it in an increment of 37.5. 37.5. So this is your step up protocol. In your step down protocol, you are starting with the higher dose, that is 150, and then gradually you are decreasing the dose. So step down protocol, so as such we don't recommend in clinical practice because that will give you more chances of OHSS and multiple pregnancy. Now you forget all these 3 protocols. Now what is the most simple, easy to use protocol in your day-to-day practice? So this is the starting dose for IUI. What we consider? The age and whether she is having a PCOS. So if her age is less than 35 years, she is non-PCO, blindly you can start with 150 dose. If she is having PCO, start with 75. If she is more than 35 years, irrespective of whether she is having PCO or not, confidently start with 150 dose. Why? Because if you give less dose, the ovarian threshold is not met, you will not recruit any follicle. So that is the mantra, that your starting dose should be optimum dose to recruit new follicles. So start with 150. Now how to monitor? Because we don't want OHSS and we also don't want multiple pregnancy. So you are giving your gonadotropin dose on day 2, 3, 4, 5, 6. On day 7, call her for transvaginal sonography. As far as possible, do it yourself. Don't depend on your radiologist friend to tell how many follicles are there, because your visual perception matters. What you will be looking on day 7? You will be looking for follicles more than 10 millimeter in size. Less than 10 millimeter, we ignore, we don't count. So more than 10, if you are having 2 to 3, you will continue with the same dose. More than 10, if you are having 4 to 6, you can continue with the same, or you can taper the dose. But if you are having more than 6 follicles, you have to taper and look for OHSS. If on day 7, you are not seeing any follicle which is of 10 millimeter, then obviously you have to increase the dose. Don't hesitate to increase the dose to 225 on day 7. If you are not seeing any follicle of 10 millimeter, it means that this ovary has higher threshold to have follicular recruitment. And when lead follicle is 18 millimeter, here you have to give trigger. Now many gynecologists, they want to combine oral ovulagens with gonadotropins. We strongly discourage, but you can go ahead, because the only advantage here you can see is that you are saving the cost of only 2 or 3 injections, that's all. It's not giving you great cost benefit, and if you are using urinary HMG, patient does not mind spending another 1000 or 1500 rupees for that, because urinary HMG now you can get in 400 to 450 rupees, 150. If you decide to go ahead with this protocol, then 2, 3, 4, you are giving your oral ovulagens, 5, 6, oral ovulagens plus gonadotropins, 7, 8, only gonadotropins, and from day 9, you will be monitoring as I told you in my previous slide. So you are clear? Standalone gonadotropin cycle, you are starting monitoring on day 7. Ovulagens plus gonadotropin cycle, you are starting your monitoring from day 9 onwards. Is there any role of GnRH antagonist in IUI practice? Only 2 indications when you want your IUI to be converted to IVF, like you have got many follicles. So you do have to give them option, cancellation of the cycle or conversion to IVF. Some couples, they do get willing to get their cycle converted to IVF, so there you have to add antagonist. Or you want to program your IUI cycle, that is her IUI is coming on weekends or when your embryologist is on leave and you can't have anyone to prepare your sperm preparation. Add antagonist so that you can avoid your weekend IUIs. Ovarian hyperstimulation syndrome, only this slide I have added because it's a potentially life-threatening complication. It can be mild, moderate or severe. In mild to moderate, it is the OPD care, but in severe cases, it is inpatient care. But before you go ahead with your IUI practice, everyone should be well versed with the OHSS management. Laparoscopic ovarian diathermy has got its own place. I know when IVF has come, many IVF people, they just say that it has become obsolete. No. If your patient cannot afford gonadotropin therapy, if she is staying in a far off area, rural area, and she cannot come to you for follicular monitoring, give them option, do laparoscopic ovarian diathermy, and the benefit is that she starts ovulating, she don't have to go for any ovulation stimulation protocol, and she can conceive on her own sitting at her home. And who are the patients who will be benefited most by laparoscopic ovarian drilling? It is the lean PCOS. So it has got its own place Don't forget laparoscopic ovarian diathermy when we are talking of ovulation stimulation protocols. Of course, when you should refer them for IVF, early, because when you refer early, patient has got highest possible chances of pregnancy, highest chances of live birth and reduction in pregnancy, the miscarriages. As such, you have to try maximum 4 cycles of IUI, and in cases of donor cycle, maximum 6 cycles you can try. Don't go beyond that. Do tell them that this treatment method is not working on you. Please go ahead for a higher method, that is IVF ICSI. So just to summarize, before Dr. Kersey takes over to you to the lab aspect, the method of ovulation selected by the clinician should be based on the underlying cause of anovulation, efficacy, cost, risk, treatment burden, and potential complication associated with the each method. Remember, even clomiphene has got the method, the complications. For oligo woman with PCOS, letrozole is the first line therapy irrespective of her BMI. Of course, you have to tell her to reduce her weight before you proceed, but practically speaking, you can proceed with your ovulation induction and IUI before waiting for her to reduce the weight, because if you don't do it, next person will definitely do ovulation induction and IUI for her. For patients with mild male factor, early stage endometriosis or unexplained infertility, remember, controlled ovarian hyperstimulation and IUI is preferred over natural cycle or timed intercourse. For women who are having hyperprolactinemia as a cause of anovulation, of course, you have to give them bromocriptine or cabergoline. While there has been concern about a possible increased risk of ovarian cancer with ovulation induction drugs, it appears that the risk may be due to the infertility itself rather than the medication used to treat it. Even then, don't use clomiphene beyond 12 weeks. Or for that matter, any ovulation induction protocols, now papers are coming that any ovulation protocol you should not use for that woman for more than 6 cycles, whether it is letrozole, gonadotrophins or clomiphene. There does not appear to be an increased risk of breast cancer with your ovulation induction drugs. So friends, this is our success story, and thank you so much for your patient hearing. Questions we will take at the end of all the lectures. Now I invite Dr. Kersey for the lab part, the semen preparation and the semen analysis.